I was walking up here, and my phenomenal resident mentees like, that's quite the topic and the big topic. I said, yeah, you go when you have Ross and Debbie invite you, it's go big or go home. And so really excited to be here and see everybody on a Friday afternoon. So today, prehabilitation, I know what it is and how I actually do it. I kind of changed the title a little bit, and forgive me for that, I took a little bit of liberty. And what I do want to call the talk is optimizing outcomes through sustained clinician behavior change. Because I think whenever we talk about prehabilitation, there's many different lenses and many different perspectives. My fund of knowledge where I work is really at the level of the clinician, and I use clinician and not surgeon specific because there's many different touch points for people who see surgical patients. And these are my disclosures. I will say we have direct funding from this work from ARC and IDDK and Blue Cross and Blue Shield, but I don't think that should bias anything that we have to say because there's no commercial involvement. So a little bit about me so you can understand what my lens is and how we're gonna move forward in this talk is I live sort of in this space called implementation science. And what implementation science is essentially a bridge between best practices, what we know we should do, and actual practices, what we are doing. And we know that there's a huge chasm there. And the space that I essentially live in is thinking about who needs to do what differently and why, and how do we create interventions that sustain, and not just sustain, but scale and stick, right? Because how many times do we throw things out there and we hope that they work, but then they don't, or they do for like a hot minute, and then, 6 months later, we're going back and having the same problem over and over again. And I do just want to make a plug, because I was just talking in the diversity session, you can do this for culture change too, because gender equity and lots of those social justice problems are the same thing, and the way that you think about them in a rigorous way really helps to push them forward. And so when we think about creating sustainable behavior change, the question is how? I think oftentimes we fall into this trap of guessing and creating interventions based on what we think, but we don't actually go back and do the deep work to really understand what are those levers, because more often than not, there are multiple levers that are needed to create change. It's not a one-size-fits-all model because there are multiple things that are usually stopping somebody from doing what they know they should do and doing what they're actually doing. The area that I focus in is at the individual level, and with implementation science, what there is a lot of really cool frameworks that you can use to think about how do I select my interventions, how do I disseminate and deploy these interventions. The theoretical domains framework works for our research, or what we think about are really well in this crowd, because this really focuses on the individual level. What do we need to do differently and why are we doing it? And that level kind of makes sense, right? Because surgery, at least for preference sensitive and benign conditions or those in which we prehab, is oftentimes the decision is made at that individual surgeon level, not at an organizational or system level. And so the goal of prehabilitation or any program, right, is to get the right operation to the right person at the right time. And prehabilitation isn't just about thinking about fluids or thinking about preoperative optimization. It's really kind of deep diving and thinking, who are we operating on? And not just who, when should we operate and what operation should we do? And I will argue that although we think of prehabilitation or we think of like ERAS mainly in the operative or the immediate preoperative space or the postoperative space, where it really lands strongest is in this preoperative space, because the preoperative decisions that we make are our untapped lever for change and outcomes change. These decisions on who we're taking in the operating room and when we decide to do that operation are really untapped levers to make outcomes better downstream. Because we know that these preoperative decisions impact outcomes. We also know that there are modifiable and non-modifiable risk factors to persons undergoing surgery. Things that we can't change are the biologic sex somebody's born with, their age, things like that, right? Like those are static things that we deal with. But there are areas that are modifiable, such as obesity, smoking cessation, glycemic control. And data suggest that if we adhere to optimization and fix these factors, that we are gonna decrease complications and we're gonna decrease episode of care spending. I'm gonna take it one step further and suggest that not only do we modify, but if we perhaps delay operations, and I know that's an uncomfortable term for surgeons sometimes, talking about delaying surgery, especially when patients want care or need care, but if we delay operations until we take care of that, we might be actually doing more to improve outcomes, and actually the risk of surgery may be worse for some patients rather than the delay of surgery for them. And I just want to introduce that concept. It's somewhat popular and unpopular at the same time, but leaving it out there. And so the first thing that you have to do when you're thinking about how to scale this is we have to identify the practice gap. So what we did in the state of Michigan is we really wanted to understand how well are we doing as a state in terms of adhering to preoperative optimization. Ryan Howard, who's sitting right here in the room with us, went through and looked at our Michigan Surgical Quality Collaborative data. We're very fortunate in Michigan that we have a consortium of 70 hospitals that input data. And we asked the first question, do we have a problem? What are surgeons going to doing across the state? And you can see that there's a vast difference. On the x-axis, you'll see the various sites across the state of Michigan, and the y-axis is the percent of non-adherence, and you can say that there's marked variation across the state. So we know that we have a target for improvement because we know that while some variation might be normal, variation, which is on this order, probably is ripe for quality improvement strategies. The second thing that you have to do is really assess the evidence and determine the barriers and facilitators for change. Why does that barriers exist? And this sounds like a revolutionary concept, but what we did is we went and we talked to people. We talked to many of the surgeons across many of the hospitals, and we asked them, we gave them kind of case-based presentations, we figured out how they would manage the patients, and then we also asked them specific questions that map to that theoretical domains framework to understand where are the levers, where are the possible interventions. And what we actually saw when we did these exploratory studies was there were three main drivers of clinician behavior. One is financial. I mean, let's be honest, we're not paid not to operate. We want value-based care. We live in a very fee-for-service world. And I can't tell you how many times I would go out and I'd have a community practice being like, you live in an ivory tower, you get a salary. Like, you don't understand what it's like to have to keep the lights on and have to, make sure all the people are employed. I'm responsible for my staff. I have to put food on the table, and this is just not how we're set up. Second main was really around knowledge and resource access. They'll say, oh, we're not Michigan. We don't have an endocrinologist. We don't have smoking cessation. Like, we want to do these things, but we can't do them because we don't have these resources. So there's like a knowledge gap. And then the last is really around practice patterns. What we came to find is there's a lot of practice conformity. So there's usually one member of the group that drives practice. And if people want to do something a little bit differently, they don't. So if they're going to operate on certain conditions at certain times, everybody is going to go ahead and follow suit. Also, local practice patterns. When you live in a small community, we would hear from providers, listen, I see my patients in the grocery store. If I say no to them, I have to face them. Or they're going to go to the surgeon down the street. Or I can't tell my referring provider that they're not going to send them here, and I'm not going to get any more patients after that. So real logistical challenges. So what do you do next? Well, you know that you have your target, you know what some of your barriers. Now you have to understand what are your theory-informed strategies. What are the strategies that you're going to pick that are going to address these in a multi-systemic way? And so the nice thing about the theoretical domains framework is it maps to this like super fun behavior change wheel. And what you can do when you're looking at this behavior change wheel is really figure out where are your levers. And so when we did that, we really found three opportunities. One was around the financial barrier. And what I did was we took this data to Blue Cross and Blue Shield and I presented it. And what they came up with was they gave us a pay-for-performance metric, which we implemented in 2021. 53 hospitals of our 70 elected to pursue and to participate in this P4P. And what it did was essentially measure site rates of adherence and incentivized sites around having discussions and treating patients in the preoperative setting with obesity, glycemic issues, and tobacco cessation. The second was a clinician-led behavior change strategy. And in this intervention, we really leveraged opinion leaders in surgery to really create a sense of urgency to deliver information and to deliver resources and allow people to understand what we do have available in statewide, national, and other resources to empower them. And the last thing we chose was on-site facilitation, because what that does is it really aligns clinicians and organizational leaders, and it really overcomes some of the power differential, or if you have a really strong and dominant force within the group, having a neutral party come in and talk about things and set standards and set expectations is really helpful. So where are we? Now we have to implement and we have to deploy, and how are we going to do that, right? So the strategy that we selected to do this is something called a SMART. And this is a sequential multiple assessment randomized trials. And that is like a super big mouthful. But essentially what this does is two things. One, it recognizes that not all hospitals need all things. And two, it recognizes different intensities and costs with various levels of interventions. So if you know not all hospitals need all things, and things are either labor intensive and expensive, then you want really a system that's designed to tell you who needs what so that you can maximize the interventions in a cost-effective way. And this is what it looks like across the state of Michigan, and we just hopefully in one day we'll get our NOA, and hopefully tomorrow, we've received R01 funding to do this. So we launched this P4P where we're just starting to get a lot of our data back, and we are actually seeing marginal but significant changes in clinician behavior just from this financial incentive alone. And so essentially what happens is we have randomized into this P4P. For sites that don't adhere, so if you don't do well with this P4P and you haven't met our benchmarks, you're either going to be stepped up to receive additional therapy, which is the clinician-led intervention, or you're going to stay the same, right? Because one could argue you just need more time and maybe you don't need another intervention, or you might need to be augmented. That gets run out as well, and you can see you stratify again by non-responders and responders, some of which you continue and some of which you step up, and you keep doing that until you get to your study endpoints. And now what you can do is you can compare outcomes and see what worked in what type of hospitals, so you know how to further implement these interventions in future states to come. So for current and future directions, we've started this, we're moving forward. It's about measuring, making sure that what we're doing is actually working. We're starting to get back some of our initial data, and like I said, we are seeing some marginal benefit, but it's not enough, which begs to the other two levels of interventions. None of this work is possible without a team. This is my team, and they're just the most amazing people in the entire world. And we have a cadre of implementation scientists, economics, behavior change. So something like this really does take a village. It really is a hard endeavor, but a completely worthwhile. And so what I want you to walk away with is, maybe you can't do this on scale in a state, but any of you can do this in your institution. And so before you do anything, whether it's addressing UTIs or CAUTI or antibiotic prophylaxis or whatever the need is really think about whose behavior you're trying to change. Is it on the individual, the organization, the statewide, national level? Do you have the data you need to design an intervention that makes sense and that's actually gonna solve that problem, right? Because if you have clinicians that aren't hand washing, and what you do is you put in disincentives and say, if you don't wash your hands, we're gonna fine you $20, but their problem is that they don't have a sink, you're set up to fail, right? Because you haven't done your homework and you actually don't know what the drivers are that are creating the undesired behavior you want. And then finally, how are you gonna measure success? What are your metrics? How are you gonna make sure those are sustained? And what are your backup plans if they're not? And how are you gonna move through and go through that? So I wanna say thank you, and I really appreciate the opportunity to be here, and I'm happy to answer any questions at the end.